Hi everyone, welcome to our live Q&A. This is one of my favorite parts of these TCOYD sessions, is where we get to answer your questions live. So please make sure and put all your questions in the chat box and we'll try and get to as many as we can. My name's Trish Santos. I'm joined here by three experts in diabetes endocrinology, all who work at the University of California. I'll let you all introduce yourselves.
Steve Edelman, and of course you better know me by now. It's a pleasure doing this Q&A session because Dr. Santos and myself, we're going to switch to first names pretty soon. We answered all the questions online, and we wanted to make this period available to you to answer any questions you want. We will respond to any questions we don't have time for. And it's so nice to have two of our colleagues, Dr. Pritika Ekanaika did a podcast on intermittent fasting, and it really bothered me because she had more listens than some of the podcasts that Jeremy and I did, and also ran rounds at UCSD on that. And then my good friend Amit Majikthia, who did not do his fellowship at UCSD, but is a super brainiac. He crosses the world between clinical and basic research, so he's really unusual that way. We'll say hello. now that I took all the work out.
Thanks so much for having me here.
Yeah, hi everyone. It's my first time here. Steve's taken me under his wing since we moved here from the East Coast, and looking forward to it.
You're not too nervous? I'm kidding.
All right, well, let's jump in. There's already questions coming in here. So we're kind of addressing questions for type 1 and type 2 in this session, so there's a little bit of crossover. But the first question that I see on both sides actually is in regards to the target glucose range. The type 2s want to know what is a normal range for after meals, and luckily the ranges are the targets are the same for both, so we can talk about that. But another person on the type 1 track asked if that time in range of 70 to 180 is safe, because they think it sounds actually really high on the high end, which it can. So what do you all have to say about that?
Well, let me answer the time and range ones, and then you guys jump in. Well, I thought that at first too, but this time and range of 70 to 180 was thought up by a very sophisticated panel and had a consensus conference, and that's supposed to include before and after eating. So if you look at the major organizations, they say your postprandial blood sugar should not get above 180. I don't totally agree with these set rules, because what if you start off the meal at 160? You're not gonna keep it under 180. So to make a long story short, the 70 to 180 is about the best number you can throw out there. And that time in range, is supposed to be 70% or greater. It's taking on more and more importance. You guys want to jump in there?
Yeah, so I think that's an excellent question, because I get this question asked many times from both type 2 and type 1 diabetes patients. I want to particularly focus on the part about, well, is that a safe number? Like for some patients, especially with type 1, they like to have their control even tighter. And I say go for it, as long as you're not suffering with significant amount of hypoglycemia. So if you can keep your hypoglycemia, under 70 to like less than an hour a day, but you are getting your prandial numbers in the 150, 160 ranges, postprandial numbers, kudos to you, that's fine. Not everybody has to fit into that 70 to 180.
And not everyone does, in fact. So the time and range is tighter for pregnant women, for example, who need to keep tighter control because the risk of fetal malformations. You need an A1C even lower, you need glucose even lower. So there's a trade-off between potentially having more hypoglycemia to have tighter control. For those of you who can think back to high school algebra, the time and range...
I don't want to think that.
Okay. Well, maybe someone out there.
There could be a couple nerds out there.
A couple of nerds out there.
I love algebra.
If you think about the A1C of 7, it's the integral over 3 months of like what your blood glucose is. The time and range of 70%, 70 to 180 corresponds to that. So it's really matched to that, and that's how they came up with it.
Yeah, and the other thing that's relatively new is that at a lot of the diabetes conferences, there's a new range, time in tight range, and that is 70 to 140. And we never even thought about ranges that tight until hybrid closed loop systems came out. Yeah, and then the last thing we'll say is, Amit is right, with pregnancy, you want to get 70% or more between 63 and 140. That's pretty tight, because it's supposed, it'll affect the fetus if your blood sugars are high. But if let's say you're older, you have a lot of medical conditions like heart conditions, then they say if you get over 50%, that's good, but they really want to limit the lows.
Right.
So they're making that trade-off. We'd rather have you no lows and a little less, in that desirable range. So it's a great question, and time and range does correlate to A1C. So you can put them both together in a way.
All right, good. I want to stay on this topic of glucose levels and checking your glucose. So there's a question that says, can you please recommend what you think is the most accurate glucose meter? And I'll broaden that out because I would say, all of us practice at UCSD, and most of the time we are actually trying to get a lot of our patients on continuous glucose monitors. I think eventually that will hopefully be standard of care at some point. But what do you all have to say about that? Maybe we can broaden it and say what's the best continuous glucose monitor, or is there one?
Well, the companies that sponsor us, obviously. Well, let you guys answer. And Tricia, please, you're an expert too, besides being the moderator.
I could start with this one. I think back when like Libre 14 first came out, and when we had Dexcom G5, 4, we're in a different era right now where the interstitial glucose monitoring is kind of matching a lot closer to the capillary regular glucometer numbers. So honestly, like a Libre 3 and a Dexcom 7, even a G6, they're becoming, the numbers you get from that interstitial glucose monitoring are becoming closer and closer to the regular capillary glucose monitor. I always encourage my patients, even if they're not on multiple doses of insulin per day, if they have the ability to be on a Libre, financially, if it's possible, I do encourage that for more of a therapeutic benefits, like whether it's a Libre or a Dexcom, but the Libre tend to be a little bit cheaper. Even intermittently, to use that as a therapeutic way of kind of, figuring out what did that meal I had for lunch or dinner do for my sugars like 2 hours after. But for all my patients who are on insulin, at least 1 shot of insulin per day, now that Medicare has like expanded CGM coverage, I do recommend doing a CGM, a continuous glucose monitor.
Really, really diplomatic answer. I would just add real quickly that when you're looking at CGM, a lot of people will test at the same time and they drive themselves nuts. If your symptoms don't match your CGM value, then let it go. We need the timer, Eric. And then if you lose that trend arrow, I think that's important. And lastly, because you get frequent numbers that change all the time with trend arrows, I think being off a little bit is a little more forgiving.
Right. So these numbers I think it's really hard because for so many years we just had, finger stick glucose. And so when they don't match, I have a lot of patients that get really scared and frustrated with that. And I think we have to remind people that, first of all, the finger stick is not perfectly accurate either. So you're comparing to something that is not what we call the gold standard. Really, the gold standard would be if you went to the lab and they drew your blood and then you found your glucose level there. So if your numbers are off a little bit, that's to be expected. If they're drastically off and not making sense, you can talk to your provider about that. But in general, they're probably not going to match up perfectly.
And we've done studies of this, we and other people, where we've looked at the Libre, the Dexcom, even older versions, compared them to finger sticks and compared them to blood glucose. And the concordance was like over 99 point something percent that maybe they were off, but you would make exactly the same decision about dosing your insulin.
Concordance mean? This is a lay audience.
Concordance. So if you draw it on a graph, right? Do they line up? If you look at blood glucose versus Libre glucose or Dexcom glucose, and how close to that straight line are they? It's never going to be perfect, but if it's close enough that you would exactly make the same decision, we consider that, and the FDA considers that to be concordant, so to speak.
Now, you have a PhD in addition to your MD, correct?
I actually don't have a PhD, but thank you for that.
For
compliment.
that, for that statement, you deserve a PhD. It concordance. No, I'm kidding. Okay.
All right. Okay, keeping along the same line, someone wrote very accurately that a lot of highs over time are not good, which we know. But why so much emphasis on the lows? Why are we talking about lows all the time? And this is a good question because I think some people think the
Go for
lower
it.
the better. Yeah, I mean, I'll start. I think, what I usually tell patients is, when we think about time and range and somebody asks a question about going high and, it seems too high, the highs really cause damage over time. You have to be consistently high over time. If you enjoy a piece of cake every now and then, your blood sugar pops up, that's not, going to cause complications over the long term. But it's important for people to remember that lows actually can cause severe problems today, right? So it doesn't have to be over time. It can cause really terrible problems now, especially if you have, it can cause enough stress on your heart to really cause dangerous heart rhythms or heart attacks or things like that. Really serious things if we want to get down to it, like brain damage and things like that. So we have to take the lows very seriously because they're a problem now.
And the other thing, oh, sorry, Steve.
No,
The
please.
other thing I always kind of counsel my patients when there's a lot of lows, when I start seeing like double digits lows and I get very panicky, and that's rare. I'm talking about the time and range, and when you see the percent lows, if you start seeing anything over like 4%, I get nervous because I agree with Trish that yes, acutely, they're very detrimental. People could have a seizure if it's severe enough. There is this, dead in bed type of syndrome where if you have a severe low, you might not wake up the next day.
We try not to scare.
But the thing I also want to talk about is the number of lows over time can have there's some correlation with cognitive issues and dementia.
Yeah.
So that can also impact you in the long term. So it is a serious thing. We do have to keep educating people about. Tighter control is always great, but not at the expense of lots and lots of hypoglycemia.
Yeah, there's, it's an important question. You could get low while you're driving and kill people in addition to yourself. You can have seizures, brain damage. So it is an acute situation. Plus, if you talk to anybody with diabetes, they're fearful of hypo. I'm fearful of hypo. I'm not to the point where I need to see Bill Polanski, but no one likes to get low. And I'll just emphasize what Tricia said, that, you really need high blood sugars over the years to develop, the eye, kidney, nerve disease. And if you read the last newsletter that we just sent out, I had a patient who had an A1C over 10% for 9 years, and she does not have any serious complications. So, which I'm surprised at. So we have to pay attention to both high blood sugars over the long term and avoid lows as best we can.
Great.
And this has also been tested where they tried to lower people's A1Cs below 7 to see if they could get even lower rates of complications. And in fact, they did. But then the flip side was that people started actually having more of these severe events from hypoglycemia, including death. And so ultimately, that's not where you want to go.
Right.
That's a great point.
It's a really good point. And I think, luckily, I think for patients with type 1 diabetes, especially these automated insulin delivery systems or those pumps that we're talking about where the CGM and the pump, the insulin delivery, talk to each other. Really, we're talking about safety, not only making life easier, but safety, right? So something that can help prevent the lows, but still keep your time and range really tightly controlled.
Yeah, I should just say that people don't realize, we look at our CGM downloads, it says the goal for below 70 is less than 4%. People don't realize that 1% is 15 minutes. So if your time below range is 4%, that means you're below 70 1 hour a day on average for the length of that download, whether it's 2 weeks or 30 days. Think about that. And then that time below 55. If you're more than 1%, it's too much.
Yeah, absolutely. All right, I want to move on and talk about a different type of insulin. There's a question here about Afrezza, which is inhaled insulin, for those of you that haven't heard of it. And somebody's saying if they cough when they take Afrezza, does that mean they didn't get any insulin, which I think is a good question. But maybe before we dive into that, Does one of you want to, maybe Preethika, do you want to talk about what Afrezza is and tell us a little bit about that?
Sure. It's an inhaled insulin and used pre-meal. It's very rapid. So the onset is very rapid. So is how quickly it gets out of your system. One of the contraindications, or what we always have to make sure before prescribing, is that the patient doesn't have any chronic lung conditions like asthma, COPD. Everybody need some PFT, so pulmonary function testing, to test their lung capacity before they go on Afrezza, because there could be some reduction in lung capacity. I'm no pulmonologist. I might be using wrong terms here. So I don't, before going on Afrezza, we need to test the PFT, so pulmonary function testing. But it is really beneficial for some people, especially when they go out and have like a restaurant meal or something where they don't want to get all their supplies out, if they're on an MDI or multiple daily injections, where they could just do 4 units or 8 units or something like that, and it like works very fast.
Yeah, it also gets out of your system pretty fast
Yeah.
too. So, you know, the studies show, I don't have a PhD, but I can mention studies, show that you have much better blood sugars after eating and less low blood sugars later on, because it doesn't hang around like sub-Q insulin. So people use it for all different scenarios. Some people use it as their only fast acting. Other people use it to correct. And so it is a unique insulin that works way faster and gets out of your system faster than the sub-Q injected insulins.
Well, on that note, there's a question here. What are your thoughts on Lyumjev versus Humalog? So do you all want to speak, maybe Amit, to the kind of rapid-acting insulins? So Afrezza is a really fast insulin that's inhaled, but we also have some faster insulins for mealtime insulin now as well.
So fast-acting insulin is, are we talking about ultra-fast?
Yeah. Yeah, the question was about Lyumjev. There's also Fiasp, which is another one that we can mention. Yeah.
Are they different?
Are
from
they better?
Humalog and Novolog?
Sure, because they're called ultra-fast, so they work even faster. And I haven't tended to use them over Humalog and Novolog too much in the clinic yet. But one area that I think they could actually be really useful is for people who will determine, their carb count, but then for various reasons don't end up eating actually that meal, or and we recommend sometimes for those people to take the insulin after the meal. And I think this kind of insulin would have particularly good benefit there, because then you know exactly what you ate and there's no guesswork, and so you can give yourself the right dose but not get caught behind.
Good point.
Yeah.
Yeah. All right. Let's talk about something else here. This is a good question that came in the type 2 track, but I think really applies to a lot of type 1s too. Is there an easy or practical way to measure a carb count before or during a meal? I wish is the general answer to that. But what can we tell patients about kind of measuring carbs? And then this person also wanted to know, is there kind of a set amount of insulin that you would take per grams of carbs that one would eat?
Well, there's this new app. It's called Carb Counting app, and you scan it over your meal, and it tells the grams of carbs, protein, fat, tells you exactly how much insulin to take. Sorry, I'm just kidding.
I think there is technology now where you can take a picture of your, I don't know what the apps are called, where you can take a picture of your food, and I don't know if it estimates carbs, but I think it does estimate some things in there.
The one that Trish actually showed me was that I really like is Figby app, because you can kind of type in what you're going to do, or like search for, I don't know, chicken Alfredo, and then like increase on the scrolling thing how big the size of the plate of food that kind of represents what's in front of you, and then it'll kind of break down all the the grams of carbs and the proteins and things like that. The other one I like for people who are like on the road and tend to be eating at like, fast food places, Calorie King, because then you can search by the chain. Like if you go to Olive Garden, you can like look up something you're going to eat there, and just figure out the carbs and estimate it.
Yeah, that's a tough question. I know dietitians that can't carb count. So the issue is this, what when we as doctors, and someone comes in the clinic and asks us, we use a formula many times based on your total daily insulin dose. We do this fancy calculation, and it gives us a place to start.
Yeah, and I think it's important to know whether you have type 1 or type 2 diabetes, first of all, there is no one formula. Your genetics kind of make up how sensitive you are to the insulin and how much insulin you're going to need for that same amount of carbs that you would eat. So there is no set formula, number one. Number two, even doctors and dietitians and diabetes educators are notoriously bad at predicting how many carbs are in a meal. And I would say the best thing you can do is practice and see, if you ate a meal and your blood sugar went sky high, then you need, if you're on insulin, you need more insulin. For people with type 2 diabetes who may not be on insulin, it's still really fun to see what different meals do to your blood sugar. I always used to tell my patients, you can go eat your favorite meal, eat, all that pizza or all of that cake, or drink a regular soda versus a diet soda.
You're
and
a popular
see what happens.
doctor, I bet.
Well, I think it's important to know what happens.
Yeah.
I think knowledge is power. And it's funny, I think some people, when they see what actually happens, that's enough to kind of change the behavior a little bit.
Yeah, and even, just say real quickly, add on to that, you eat something with a food label. You don't, so that way you're eating exactly, and it says how many grams of carbs. You take a certain amount of insulin, and then you follow yourself for the next 1 to 2 hours. You can see how close you got. Yes, Amit.
So Trish, to your point, even if you eat the same carb amount, and it's the same person, and you do it like one day and another day, you can get like a different spike in your blood sugar, because there's so many other factors that are important, like
So true.
how well you slept, if you're sick or have a cold or not.
Menstrual cycle for
Oh,
women.
yeah, that really messes me. No, the time of the day,
Yeah.
because morning you're way more resistant. So you're right. That's such a great point.
And activity, I think it's another big thing, right? Like if you exercise or even go on a walk, you might not need the same amount of insulin that you had for the same meal the day before.
It's not an exact art, and that's why we get so many questions about it. Everyone's told to carb count, but it's tough.
On a hopeful note, I do want to, the question was, is there something that will tell me how many carbs is in what's in front of me? So I had a chance to beta test this Google-powered sort of image recognition app, and it was good enough that I took a picture of soup dumplings, and it gave me the name in Chinese and like taught me something.
Wow.
And so I think that it's not there yet, and it wouldn't tell me how many carbs were in the thing, but I think that technology with AI and image recognition is coming. So just like now we have the artificial pancreas, I think this is coming right around the corner.
It's definitely
For
coming.
sure. Let's stay on that topic of carbs. There's a couple of questions here. One says, why are we told that we need to eat every 2 to 3 hours? And I think this is a common misconception maybe that we can talk about in diabetes. And then another question is there a minimum number of carbs we need to eat? So, do you have to have, if you have diabetes, do you have to have carbs in every meal? Do you have to have a snack every night? I think that's something that some patients were told a lot historically. Do y'all want to comment on that?
Well, I can say one quick thing. In the olden days with insulins that weren't as long acting as the basal, people told their patients to eat a morning snack, a mid-morning snack, lunch, a mid-afternoon snack, because the insulin peaked at the wrong time. But if your doctor's telling you that now, your doctor is from 1909. Or you're on an insulin regimen that's just not modern. But we don't have to eat every 2 to 3 hours, period.
Yeah. And the other thing I'll say just for the patients out there is that if you have to eat in order to avoid a low blood sugar, then your medication doses are too high. So your insulin, or for type 2s, if you're on, medications like glipizide or glyburide, you shouldn't have to eat to prevent low blood sugars. So it's important to understand that.
And I think part of the other question on that string of questions was like, how little amount of carbs do I intake, or what's the minimum amount of carbs can I take? I have patients with like type 1 who are doing more keto type of a diet, and there's nothing wrong with that. Often people find when they really eliminate carbs, it gets slightly easier during mealtime to keep their numbers flat, especially that immediate postprandial spike without the carbs. So I wouldn't mind if my patients do keto type of a diet if that fits their lifestyle.
Yeah.
I think you have to do it carefully, though, and particularly with people with type 1 diabetes, because I've had patients who they got sick, and so they essentially put themselves on a keto or starvation diet because they just didn't feel like eating, and then ended up in the ER with DKA, but their blood sugars weren't even high. You know, we call that euglycemic DKA. So you have to have some carbs to prevent your body from going into ketosis and then having DKA, and particularly if you're on it's not type 1s, but type 2, if you're on these SGLT2 inhibitors like Jardiance or Farxiga or other things, you got to be careful with ketosis.
For sure. If you have type 2 and you're taking Jardiance or Farxiga or these medications, you definitely you want to stop taking them when you're not eating. So if you're too sick to eat, or you have a surgical procedure, you want to hold it for 3 days before, yeah, absolutely, to avoid that. On that topic, there is another question here about Jardiance, and it says, what if someone has a lot of urinary tract infections and they're taking Jardiance? What do you have to say about this? And let me back up a little bit. So if you've been around at these TCOYD events, you've definitely heard us talking about Jardiance and Farxiga and SGLT2 inhibitors, because really, in a lot of ways, they should be in the water. I mean, they are, protecting our hearts, they're protecting our kidneys significantly. So they're wonderful medications, and we really promote them. But they do have a few of these risks, right? So what do we tell patients, who may be at risk, higher risk for infections?
Well, we should clarify the difference between a yeast infection, what we call genital mycotic infection, and a urinary tract infection. They're quite different. And the one that's the genital mycotic infection, yeast infection, is the one that's most associated with these SGLT2 inhibitors like Jardiance, Farxiga, because you're pushing urine out, you're pushing sugar out into the urine. So typically, we tell people before they start it, if you have these quite frequently, typically a female obviously, then it's their choice to try it and have something at home to treat it if they do get it. But it's up to the user if they want to use, because as you know, Trish, people love these medications. Helps with their diabetes, helps a little bit with their weight, but now we know it helps with their kidneys as well as reducing congestive heart failure. So, yeah.
I do think, so, if this is something, if the question is like, if this is something, recurrent UTIs that started after going on something like an SGLT2 inhibitor, then it is good to talk to the prescribing provider. I often tell my patients, like when I start them on SGLT2 inhibitor, if they never had, recurrent yeast infections, do tell me if something like that happened. One-off, if that goes away and it seemed like a coincidence, we can always retry, but with the caveat that, look, if it's recurrent, maybe this is not a good option for you.
And every medication is a risk benefit, right? We're always kind of going like this, like what's the benefit we can get from the medication? What's the risk? Certainly, I work in the hospital with people with diabetes, and we do see people that come in with terribly severe infections that are probably not all related to these medications. They're actually, there's another cause of the infection. But if that's the case, if you've been hospitalized because the urinary tract infection has been so severe, or the groin infection, yeast infection has been so severe, then that's another story. But the run-of-the-mill kind of outpatient ones, then it's like this risk benefit. On this note, we also talk a lot about GLP-1 receptor agonists, which is another class of medication that we're always talking about here at TCOYD. Again, this one should also be in the water as far as I'm concerned. So these are the ones that help with weight loss significantly. They reduce the risk of heart attacks and stroke. And there is more than one question in here from patients asking how can they afford them. And I think this is a really important question to address, and also a question about cost of insulin, because, everybody's trying to get these benefits of these medicines. So what do we do?
Their marketing name so they know.
Yeah, so people are talking about Mounjaro, they're talking about Ozempic, Trulicity. These are the GLP-1s that people are talking about. And even Wegovy and Saxenda, those are kind of the names of the same medicines that are approved for weight loss.
I do think we're in a good period of time though, because, with the ADA new guidelines, it's not like, well, it's metformin and then, try these things. And then if they don't work, go to these better agents like a GLP-1 and SGLT2 inhibitor. For most patients now, if they have had a history of coronary artery disease or heart failure, history of chronic kidney disease or spilling protein in the urine, these drugs are more first line, like SGLT2 inhibitors and even GLP-1 agonists, especially if for the GLP-1 agonists, if there's some obesity type of issues, overweight, that is something that I would reach as a first line, along with metformin, and I'm specifically talking about type 2 diabetes here. So I think we're in a different time than even several years back when it was like nearly impossible to get some of these agents for some patients depending on their insurance.
Yeah.
I haven't really run into a lot of problems getting them. Co-pays might be still an issue, but then we have so many GLP-1s that we can move on to something different. If Mounjaro is not first line, I could try Trulicity.
Yeah, and I think it's important to ask your provider if you do have heart disease, if you are overweight or obese, these medications, some of them are FDA approved to actually treat that, not just the diabetes. So sometimes the insurance will cover for that reason too, if your doctor just tries something else. So that's another thing to think about.
And now that includes kidney disease and heart failure as well.
Yes, for those SGLT2s, yeah.
Those drugs aren't officially approved for people with type 1, but let's say your BMI is over 27 and you have other risk factors like high blood pressure, cholesterol, you could get these GLP-1 drugs for the indication of weight loss. And if you don't have any issues at all, then the rules are you have to have a BMI over 30. So even type 1s can be approved for some of these high-dose GLP-1s.
Yeah, for sure.
I have several patients on things like Mounjaro who are type 1 because they have significant insulin resistance. They're on, even through their pump, over 100 plus units of insulin per day. So.
And type 1s are getting heavier. Look at Dr. Pettis. He's in New York now eating everything in sight. That's why he's not here today.
Yeah, no, and these medications for you type 1s out there, they really do help with blood sugar control as well. Most people who go on a GLP-1 who have type 1 will see kind of improvement in their time in range. So there is benefit for everyone with these meds.
Could I ask a question that was part of the conference today? As you all know, these drugs lead to a lot of weight loss. That's why there's a shortage. Oprah Winfrey's on it, Elon Musk, anybody is on it. And the main question I got several times was, what happens if you stop? Will you regain the weight back?
Yeah, and the answer is yes. The data shows that when you stop these medications, people do regain the weight. I think it goes back to really remembering that obesity is a disease. It's a genetic disease. And because of those genes, we can't really control how our body responds to food and insulin resistance and weight. And so while the medications are working really, really well, you have to kind of think of it as a long-term disease like you would any other disease. If you go on a medication for blood pressure, you don't generally come off of the blood pressure medication, right? If you go on a medication for cholesterol, you don't generally stop that medicine. And the medicines that we use for weight are the same. If you go on a weight loss medication, the idea is that you stay on that medication.
I want to echo what Dr. Santos is saying is, because what these medications do is they actually rewire your brain to stop craving certain things, and that desire to eat, that dopamine hit that you get from eating, reduces the reward of that. And so these medications are even starting to be used now for things like alcohol addiction and substance addiction because they have those properties. But what you're working against is millions of years of human evolution where we're wired to eat everything in sight because food did not used to be plentiful outside these past couple of hundred years. And so that is almost impossible to fight with quote unquote willpower. And so when you come off the medication, the body just goes back to what it was hardwired to do.
Yeah. What I tell my patients is this, that these drugs protect your heart and your kidney and keep your glucose down. You don't want to stop these drugs.
Yeah, right.
Because, our mindset is, when could I get off of it? You don't want to get off these drugs. They have too many benefits. And you're right, Amit, it's so hard to fight I call it Mother Nature, what's wired in your brain, as you said it. And that's why it's so difficult that when you stop it, even if you say to yourself, I'm going to really change my lifestyle, I'm going to exercise more, I'm going to pick better foods, you end up going backwards.
Yeah.
It's the rare person that could keep it off.
I think it's nice though to think of it, and I'm always thinking, just because I echo that it'd be nice to do things naturally. I totally agree. Like, it'd be nice to not be on anything. But the way I kind of reframe it is, let's say you were on, a lot of insulin, like couple doses of mealtime insulin, and then long-acting insulin, and then we end up introducing these GLP-1 agonists to kind of try to minimize the amount of insulin. I have had patients who ended up going from all that insulin to just one GLP-1 agonist once
With
a week.
type 2.
With type 2. That's it.
Yeah.
So they get
Yeah.
rid of a bunch of medicine,
Yeah.
and they're just on this one medicine. And that to me is a success still, even though you didn't get off of everything.
Right,
Yeah.
right, absolutely. All right, moving on. So this question says, moving into a little bit more of the type 1 space, what is the latest news on the artificial pancreas? And I'll ask a little more specific about this. There was a question on the type 1 track earlier today that was pretty detailed that said, of these kind of artificial pancreas systems, what's the best one? What do you think about that question? What's your answer? I mean, I can give you my opinion, but...
Go first.
What I briefly said this morning, but we didn't really have time to get into it, is that there are several different systems now that are working with continuous glucose monitors to modulate the insulin delivery, give you a little more when you need it, give you a little less when you need it. And it's really cool because there's options. And I think there isn't a one size fits all. I think there's patch pumps, there's pumps that have tubing, there's pumps that have maybe better if you're an exerciser. There may be a pump that's better if you don't like being engaged with your diabetes all day long and you really want to let go. There's a pump for that. So it really goes into what your kind of biggest need is.
Yeah, I'll just add that, I have patients on all of them. I use one myself, and to me, 80% of success, I'm just picking that number, most of the success is the system. And you're right, they're all a little different. But the other 20% is based on the individual that use them. All of us see patients where they come in, they're on a hybrid closed loop system, and they say, man, you are really not doing well. So it's not an automatic fix. As an individual wearing one, you got to do your part too.
And I think, the latest one, the islet, the bionic pancreas, it's becoming more available, definitely through commercial insurances, but eventually Medicare and some of the Medicaid will cover it, and any of the government insurances like TRICARE. But one benefit of that I see is that, and I often have to talk to my patients who are already on an AID type of pump, that if you're ready to kind of like let go of some of the control, like micromanaging, you could do that with the bionic pancreas because you actually physically cannot do much with it, and we can't do much with it. There's no settings to be set. It just your body weight, and it just goes based on the algorithm. So for patients who are kind of like been dealing with type 1 diabetes for a long time and they're ready to take a back seat, bionic pancreas might be an option if the insurance covers it.
That's a great point. I've found that of my patients who we try this on, so some of the ones who have the toughest time accepting it are the people who have been managing their own diabetes with multiple shots of insulin or even a pump over decades, because you have to kind of let go of that control. It's almost like some people like self-driving cars and some people don't, because they can't give up that control, or can. And I found also with the different brands that are out there, it is an individual choice, and I wouldn't say that one algorithm per se is better than the other, but the patch pump, for example, one of my patients was, he welds inside of like naval ships, and so the tubing of the tandem wasn't working for him, and so we had to put him on one with a patch pump because that kept getting snagged. So there are a lot of different factors that can go into making the right choice for you.
Yeah, I'll just say, Pritika talked about the islet. The only thing you really have to do that you're supposed to do is announce your meal, small, medium, or large meal. There's no carb counting. So for all that discussion, carb counting goes out the windows, and it's just like everyone said, it's letting go, and the control may not be as good as some of the other systems, but I think it really depends on the individual user.
Yeah, and I think for all you type 2s out there, the exciting thing is this technology is available. There are type 2s using this technology, and I think it's only going to get
approved.
better. Yeah, Medicare is approving it. And I think the best part is that, like I said, there's choices for people who type 2s even who may be on insulin. And I think just to wrap up, because we're out of time, this always goes by so quickly, I think I'll just say that there really has never been a more exciting time to have diabetes, believe it or not. So it's a really exciting time. There's new technology, there's new medications, and lots of cool benefits out there.
Yeah, thank you all. Stay tuned for this last session too. You're going to see me dressed up in a Darth Vader outfit and fighting my young son. And I hope you enjoyed the day, and thanks so much for joining us today.
Thanks for having
Yeah,
me.
Our new
thanks
star,
everyone.
Amit, and Kritika's already been
Thank you,
on
Steve.
set.
Thanks everyone.